Excellent. Well, good morning, everybody, and welcome to our webinar with the title of Using Automation to Secure Reimbursement. Obviously, very much healthcare-driven event, one of many webinars that Digital Workforce runs every year. My name is Karri Lehtonen. I'm the head of sales for North America for Digital Workforce. I've been with the company a little over 5 years now in various roles, and super excited to be here today with my colleague Tom. I'll quickly just explain who we are as a company. Some of you might know us, some of you might not be familiar with Digital Workforce. We're an automations company founded 9 years ago, pretty much around healthcare automation. We are based out of Helsinki, Finland, over in Europe, but have a significant presence in the US market as well, and very much concentrated on automating the health systems and the different processes around health systems. That's by far our biggest vertical, and our most expertise lies in that particular industry. I have with me here Tom Herrmann this morning, and Tom he joined Digital Workforce in February this year, but has worked 15 or over 15 years, I should say, in the revenue cycle management roles in various health systems, and the last 4.5 years as a consultant helping various health systems to improve their revenue cycle management practices and whatnot. Tom works for us with the title of Vice President for Revenue Cycle Transformation, which pretty much sums up what we do as well. So we help to improve and in transformative ways make our customers' lives a bit easier. And today we're going to talk about a couple of different use cases that we have built for different customers, and Tom is going to walk us through those ones. But just before we unleash Mr. Herrmann here, a couple of housekeeping items there. At the bottom right-hand corner of your screen, you should see two buttons. One is chat. The other one is titled questions. You can freely submit any questions during the webinar as you please. On the questions tab, they should be anonymous. So if you don't want to show your name, use that one. If you want everybody to see who's asking the question, you can use the chat button as well. You can use the chat button to give us feedback and whatnot as well. But with that, I think we can kick off the webinar, and I'll hand it over to you, Tom, to introduce today's topic.
Excellent. Thanks, Karri. So yeah, great to be with everybody today, and we're going to be talking about a couple of revenue cycle and patient access automations that we have in process with clients here in the US. Those are mainly focused on large academic health systems, but they're very applicable to other organizations, even small community hospitals, all the way up to the large all the way across the country type of health systems, like Ascension and different groups like that. So the first topic we'll talk about is one where we automatically are sending appeal submissions. So everybody understands that in healthcare, and again, I've worked in-house in revenue cycle and patient access for a long time, is that there's a lot of stuff that we have to appeal. We don't always get paid for the care we provide, and we don't always get paid the right amount for the care we provide. And so one of the automations that is in place is to automatically make those appeals. And I know there's a huge volume of those, and we as healthcare practitioners and in revenue cycle, we can't always get to everything. And so what we did with this client is we looked at some of those underpayments that always come in. They come in from the same payers. They come in for like ED visits and different things like that. And a lot of times they're small dollar. And when I say small dollar, they're a couple $100, maybe even 1,000 or more. And we just don't have the people and the staff to dedicate to appealing those and getting those overturned. So what a lot of us end up doing is unfortunately we simply ignore them and we say, okay, we'll take what we can get and we'll move on, and we're going to go after the bigger fish, right? The $30,000 denials for surgical cases and different things like that. So one of the things we looked at with our client was, all right, what can we do to try to bring that revenue up, right? And so these are things that aren't being worked today, but can be worked by an automation if we put it in place. And so what we did is we looked specifically at underpayments. We looked at them for a subset of payers, because you want to start small. You want to make sure that the efficacy is there, right? Just like with medicine and other things, you want to make sure that the juice is worth the squeeze, so to speak. And so we started out small, doing automatic appeals for underpayments. So this customer happens to be on Epic, and so you load your contracts in, and Epic can identify when there's an underpayment based on the contracts. And so what we did is once those are identified, they actually go into a separate work queue for an automation to work those. So a bot, people know the term a bot, right? And so bot will go in and automatically make those appeals through the payer portal. Now I know with Epic, right, there's the payer platform. So we don't want to focus on those because there's already connectivity there. But what we do is like Medicaid, right? Your state's Medicaid they don't have payer portal, or sorry, they don't have the payer platform within Epic, and they're probably not going to. So what we did is we made a connection between the payer portal, and we can automatically submit those appeals for underpayment saying, hey, the patient came into the ED, you paid $67.14. That's not accurate. And a lot of times you can identify those really simply with payers because they always pay the same amount when they just want to pay you a low, small fee for whatever service it is. And so we're automatically appealing those using the bot and using the payer's portal. And so this automation started in January, and I know it takes a while to see the fruits of those, but we're starting to see larger payments come in, and they're accepting those appeals that said, hey, this is an underpayment, this was an ED visit, it was blah, 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 blah. And we're starting to see those payments come in. So as we see more of those payments come in, of course, we'll share them with the community, let them know what's going on. But it's been a really great additional revenue stream for the organization because these are things that typically would just not have been touched. They would have just accepted the payment, and so it's kind of just money sitting on the table that you say, okay, we'll accept the lower reimbursement for those. And I also know, a lot of organizations will outsource that, right? You'll just immediately send it to an outsourced company, they'll do the appeals, et cetera. And maybe you get back 30 cents on the dollar or something like that. They take a portion of it because they're doing the work on that. If you're already doing that, and this is the other area we're exploring, is that, hey, before you send it to the outsource company, let's put it through the automation and do this automatic appeal. And then if they still uphold the appeal, then those can get sent to the outsource company, but you can knock off 20, 30, 40% of those and then actually lower your outsourced vendor costs and actually gain more of that reimbursement. So it's kind of twofold. It's things you're not getting to and things you're outsourcing because you just don't have time to get to them. And rightfully so, you want to get some money, but you're just outsourcing them. We can run these automations fairly inexpensive, certainly less expensive than your outsourced company, and gain you that additional revenue. And then if you need to, if a person really needs to look at that and like make an appeal letter and things like that, then that can still go to the outsourced company and they can do that. So you still gain that revenue. So there's two opportunities there. So that's really the first automation we'll talk about. The second,
can I pause you there? Just a couple of questions on that. So you mentioned small dollars, like individual amounts of small dollars, hundreds of bucks or maybe $1,000. By your experience, and we don't need to talk about this particular end customer or anything like that, but your 15 years of experience, how much does that add up in a sizable health system over, I don't know, 12-month period or something like that? So
yeah, Even for a mid-sized healthcare system, I mean, this can be millions of dollars. And in general, we can be talking about any dollars. You can be talking about 25. But what we're looking at is like 200, 300, 400, maybe 500, occasionally a couple $1,000. But when you're talking about, for example, like an ED visit, is, many organizations have 100,000 of those. And so if you have $100 payment for $100,000 or 100,000 visits, you're talking about millions of dollars every year. And I know, the revenue cycle folks, especially who do the write-offs here, like,
Yep.
that's not an uncommon thing to write off that amount of money because you simply can't get to it. And I get it. We don't have people to do it, or, you have people that you want to prioritize on other areas. And so it can really add up. And, those small dollars, and that's just talking about like on the hospital-based care. If you're talking about appointments and other things like that, it's $25, $30 here, but the hundreds of thousands of those appointments, they add up very quickly. And you can have an automation that just automatically does that. Even if the yield is only 20 or 30%, you're still talking about $500,000, $1 million a year in added revenue that you were never going to get because you never worked them at all. And that's the reality in US healthcare, is that there's some stuff we just never do.
Makes sense. Yeah, and automation is obviously, not anywhere near that expensive, so your ROI is fantastic on these things, because it's money you're leaving on the table as well. It's pretty common actually across different industries. It's not only healthcare; it's in other industries as well.
Yeah.
One quick comment as well. We don't talk about bots. We talk about digital workers. So
yes.
As you move on with your speech,
yes, our digital workers.
Yeah, exactly.
We do a lot of work, and they work 24/7.
Absolutely, that's good stuff. Well, that was super interesting. I know, obviously, this probably every health system, every hospital will have the same issue, as you said. The payers are what they are, and they have their ways of dealing with things, and this is probably it's the same thing, but they're just on the other side of the table. They probably don't like these automations too much because it's we get to money which they get to keep at the moment. So that's an interesting scenario from that point of view as well. But yeah, let's move on. I think we're talking about prior auth in the next automation. And go ahead.
Yeah. So moving further up the river here, so to speak. So further upstream on the workflows are prior authorization. And now I don't have to say what these things are. It's in the news. Congress has had hearings on this. It's a challenge for everybody. Is more and more things require a prior authorization, and it's only more complicated. It's not getting easier, unfortunately. And so making sure, as we look at the whole revenue cycle stream and how everything works, getting that prior authorization is really high on the list, because now a prior authorization does not guarantee payment. And I know everybody on this call knows that, but no prior authorization guarantees no payment. So it's a little bit of a, I want to say double-edged sword, but it's more like a sword with two ends that can chop your head off. I don't know what I want to call it there, but it's a really high fact of life for healthcare organizations, provider, physician organizations, everybody. They have to get those prior auths. And so there's a couple. So I'll just really generalize. So prior authorization, you've got to submit information to the insurance company that says, hey, Tom has bad ankles, which I do, and he needs to get an MRI. These are the things I have done for Tom so that he can now get an MRI, and this is why I need him to get an MRI. That gets sent to my insurance company from my physician's office, and the insurance company says, okay, we think Tom needs to get an MRI. And so it's authorized, and then I can go ahead and get my MRI. If organizations go ahead and do that MRI without getting that prior authorization, there's a couple of issues. One, they're not going to get paid by the insurance company, and that's a bad thing. Two is those companies, if they are contracted with that insurance company, usually in your contract, it says if you do not obtain a prior authorization and provide the patient care, you cannot charge the patient for that care that you, except for like their copay or whatever. And I'll be honest, this has happened to me. So the hospital, the healthcare organization is the one that has to eat that cost. And to be honest, that's not fair. But it is what it is. And so one of the things we wanted to do is how can we secure those prior authorizations and make sure you get compensated and reimbursed for the care you provide. And so a lot of organizations have tried to figure out how to do the submission of the authorization. And it can be complicated because you have to go into your EHR, you know, you've got Meditech, you've got to find the correct note, you've got to send it to the insurance company. That's a complicated process, you know, and so what we did is we worked with one of our clients and we said, all right, instead of trying to submit stuff because it's highly complex, let's look at what I call pinging the payer or pinging the portal. And so what we did is once something is submitted, the RFL is status as pending, and that's when the automation will pick it up. And what the automation will do is it will take that reference number that the human put into that RFL record for that encounter, and it will go into the portal and use that reference number and patient information from the EHR. It will go into the payer portal, find that patient, find that encounter, and update the status. And so what it does is it goes out and looks at that and brings that information back. And so I've been in this place where I've managed hundreds of people that do this. Is like they have one screen up here and then one screen over here, and they're looking back and forth all day long trying to update this stuff. And one, they hate it. Two, it's not a really great use of their time. And so what we did is we said we can have an automation do that. So it'll bring back the information. Let's say it's still pending. It brings back that information, puts a note into the patient's record that, hey, I checked on the 1st of October, it's still pending, and then moves on. And then does it the next day, and the next day, and the next day. Now, let's say it goes into that portal and it finds something odd, right? It's needs more information, right? We've all had that where they say, hey, we need more information, why Tom needs an MRI. And so it'll bring that information back into your EHR. And what you can have it do is change the status of the RFL record or whatever record it is you're using and say, hey, needs review. And so that's a trigger for a person within their work queue or work list or whatever it is you're using to filter by that and say, hey, I have to review this. The automation says this needs review and it says needs more information. Now that person can be like, okay, I'll go find more of Tom's appointments with this orthopedist that showed his ankles are blown out, and submit that, and then they change the status back to pending, and the automation picks it up again, and we'll check it again the next day. The other thing, maybe a peer-to-peer is required. It can bring that information back, change the status to peer-to-peer required. Now, based on your organization, maybe that automatically triggers it to go to the physician that says, hey, you got to call this number. There's a peer-to-peer. Or again, that could just be a trigger that says, hey, a human has to look at this. The other thing it can do, which is fantastic, and we really like this, is it's approved. So brings that information back into your EHR, changes the status to approved, brings the referral number back in, also adds in like the number of visits. Let's say I was looking for 15 PT visits and they approved 10. It'll bring that back in and put it in to say, hey, 15 were requested, only 10 were approved. And so again, that then falls into your normal workflow that says, hey, there's a discrepancy here, you've got to change appointments, et cetera. But it gives you all of that information. It also gives you the validity date. So like a surgical case, right? is only valid for like 3 months. So it says, all right, it's valid 10/2 to 2/2 of 25, right? It'll bring back those dates and put it in your system. So if you schedule that outside of that February 2nd, 2025 date, it'll say, hey, this isn't authorized for that date. You need to schedule it in January or something like that. So that's kind of what we've done with the authorization status check. So I know I talked a lot right there.
No, it's super.
Questions, so I'll let Karri take over.
Super interesting. Obviously, it is. I know it's a big topic, and we talked about it last week in the healthcare summit and whatnot. And it's everybody's kind of like the health systems are struggling with the prior auth, and it's basically it's kind of like no PO no pay what the big companies are doing to their suppliers and whatnot. And I can kind of relate to that. We had a couple of questions coming through already, and pretty biased on this one myself, but I'll let you answer it. So I'll just ask the questions. What would be the recommended go-to technology for a process like this? Like, I know what our preference is, but let's be objective about it. So, what do you think would work best?
Yeah, so I see Amir asked the question, what tools are you using to build this automation? So I'll be really quick on this. So our platform, we can use any of the technologies. So we can use UiPath, Blue Prism, Power Automate. There's a lot of different technologies we can use, and they all live within our platform, and you can use them as you wish. I believe for this specific one with this specific client, we're using UiPath. And so for the authorization one, it's pretty simple. It's just taking information out of the EHR, logging in to the payer portal, and then getting that information and then bringing it back. And again, I'm less of a technology person, although I can be dangerous. I think that's the pretty simple explanation for the technology that's being used. So it's really just RPA.
Yeah. Absolutely. And yeah, we had another question. How long would a typical implementation or development time be for something like this? I mean, of course it varies. It's a kind of a question of how long is a piece of string, but what are we estimating?
Yeah, I mean, honestly, implementation time for this, I would say 6 to 8 weeks. The biggest thing is getting the process definition document, which probably most people know as a PDD, together, and so that you really understand the process. I would say that the things that you want to do while you're developing that is making sure you have a good process, because we don't want to automate a bad process, because then you just hyper accelerate bad practices. But it also, as you're developing the process, you want, if you can make improvements to that or make it more of what I call a candidate for automation, it's going to make the automation run more smoothly, and also just run more quickly. So you're not using as much time on the virtual machines, and you're doing these things more quickly. So that's the estimate on the time for this specific one.
Yes, pretty quick. All up. We have one more question, but I think we're going to save that for the next session, because it kind of ties in very nicely to the third topic of today. So let's park that for the moment.
Sure.
And let's move on with the agenda. So let's go to the integration with EHR systems.
Yeah. So integration with your EHR. So it's become increasingly important, I guess, that healthcare systems use one simple platform, and a lot of times that's Epic, or it's Cerner, or it's Meditech. And when you're doing a lot of these automations, you want them to kind of integrate seamlessly with their workflows. You don't want to have to then add another system where they have to go look at stuff. And so that's one of the principles we use, is making sure that all of these action items, so to speak, that people need to do or anything ties back into their EHR. And what I mean by that, well, there's a couple aspects of that. Is one, and again, I'm an operations guy, and I don't want my team having to look at Excel documents and going into a different system and logging in to get authorizations or to do X, Y, and Z. I want them in Epic all day long, and to be able to do their work within Epic or Cerner or Meditech or whatever it happens to be. And so when you're building your automations, I would really encourage folks to think about that and how it ties back into their EHR. So if I look at the, I'll just look at the auth one real quick, is bringing that information back into the EHR so that it's actionable within a person's normal workflow in their work queues, right? That's really important because I don't want them having to look at other systems, and I want it to be front and center on their computer screen. They already have enough to do. Let's make it as simple as possible. And so, and then also once you change statuses and stuff, it's like the automation is working with you over your shoulder, like as a helper, an assistant. And so that's what we're really striving for. The other thing I would say is that for reporting purposes, like we all have productivity reporting and all kinds of different stuff. You want to think about how you can integrate your automations into your current reporting. And again, you want to get those out of your current system. You don't want to have to go to UiPath or to Blue Prism to try to get the reporting and figure out how it works in your EHR. And then then you have to do like a report out of your EHR and Blue Prism and then match them up to see how things fit. You want to try to integrate that reporting into your EHR. And so I think a really good example is actually the appeals automation is like, I can tell you out of UiPath how many appeals have been submitted, right? But I can't tell you the results of that because the automation never gets that information. That happens like 2-3 months later when the insurance company finally pays. And so if you can identify within your current reporting structure, within your EHR, how to identify, oh, these appeals were done by the automation, then you can 3 months down the road on your overturns or whatever reporting you might have, you can identify what was done by the automation and how successful it was. And that's a big component to driving ROI. And leadership is really going to want to see, all right, we're paying money to have this thing do these automatic appeals. In theory, we understand that that's a good thing, but where does the rubber meet the road here? How much have we actually appealed? How much has been overturned? What is the yield on that? And is it valuable? And that also goes to scalability. Once you can identify that something has been valuable, you can then scale it. And again, and I'm getting a little off topic, sorry, I do that. Scalability of your automations is really important as well. And I always say start small, get a proof of concept, make sure that it works, but also make sure it's scalable. So like the authorization one, we're doing this with just a small number of payers that are trouble payers that are challenging. But as we start to do it, let's just say you start with radiology, right? And you're only doing imaging and different things like that. You already have this connection with, let's say, Blue Cross, right? And it's going back and forth and working really well. You can now start to put surgical cases. Let's say we start to put rheumatology through it, or however your work queues are kind of divvied up, and you can scale it. All of a sudden, now you're doing your cardiac surgeries through it. You're doing all this other stuff because once a person submits it, it's really just a checking game, right? That's all it is. So think about how you scale those automations as well. And now I'll shut up because I've been talking a lot again.
No, that's super interesting. And obviously, I mean, let's go to the question we parked a little bit earlier, which was, and I love this one because we get this a lot in different discussions that we have. Is you get any pushback? Emphasis any pushback from Epic with respect to the integration you've been making with Epic?
Short answer, yes. They are protective of their EHR, and rightfully so. But we work in very close conjunction with them. So we have all the vendor agreements, et cetera, with Epic so that we can use it. But we also meet with them. So a lot of organizations will have TSs and other boost resources, et cetera, that work with them. We want to check to make sure, hey, this is the automation we're going to do. Do you like it? Do you have any suggestions, et cetera? They might say, hey, we would rather you use an HL7 message than use graphical user interface to do this stuff. Awesome. Thank you. And they've been actually really good working with us and saying, yeah, we like that. That sounds really cool. Tell us how it works. And they're actually interested in it because, it's not a secret. Epic is looking at automations as well. And they're interested in learning from the things healthcare organizations are doing, but also what we're doing as a partner with them. And they want to learn as well. And they don't stand in the way. They want you guys to be successful. And I think that's the really important thing is they're not the enemy. And some people will say that. They just want to understand what you're going to do with their system and just have a say in it. And I think that's absolutely valid. And I really actually appreciate their collaboration in that. And all the things we have done with Epic specifically, we make sure to get their input and sign off. They don't technically sign off on it, but they're kind of like, yeah, that sounds good. We like that. So we work very closely with them.
Yeah, I like that. That's always been the approach we've taken. We've obviously on this side of the Atlantic, we worked with the with Epic customers since I believe 2018. So it's been a long journey, and in the beginning, we had to explain to them like what is this automation stuff? Like, what are you trying to do here? But we did it in collaboration with them, and that has been the key to our success in the way that we know we don't do anything behind their backs. That would be foolish, right? So it's actually better to involve them in the discussions, and they hardly ever have any negative things to say as long as they're kind of kept in the loop and they know what's going on. And that's a quality assurance thing as well, in my opinion. It kind of helps to avoid any pitfalls that could otherwise appear on the down the road. So I think it actually makes sense, and they have a reputation of being a little bit difficult at some points, but I think they have a good reason for it. I think they're looking after their own customers, and as long as they're kept in the loop, kept informed, and whatnot, I haven't found them to be difficult in any shape or form. We got a couple of other questions as well. There was a question of how do we work with Epic, and I think you kind of touched on that already. And we can talk about a lot more about that. It kind of goes the same thing with other EHR systems. It's not limited to Epic by any means. Epic is the market leading system, obviously in the US, but there are other ones like Cerner and Meditech, as you mentioned. So,
yeah.
There's a very specific Epic question here. Are you doing any integrations with Epic's cognitive services for predictive models and tying that into automations? I have to admit that I'm not an expert on this one, so you're gonna have to take this one as well.
Yeah. Again, I'm not on the technical side. When they say cognitive services, I'm guessing they're talking about kind of ambient listening and different things that providers use. It's not outside of scope. Again, we can integrate with anything. I think in the US healthcare market, and again, this is more my personal opinion, we're focusing on areas that are less about that are less focused on direct patient care because overall the industry is a little bit hesitant on doing that. It's just when it involves direct patient care, people are a little scared to be the first to try automations and to try some of these different technologies that interact directly with the patient. I would say, and I'm actually really encouraged of the stuff we're doing in Europe, they're a little bit more inclined to do some of those things. So I hope to be able to bring some of those automations and experiences over to the US to show, hey, we've been doing this for years. They're really happy with it. You know, we can try it here in the US on a small scale, et cetera. So that's kind of how we would be integrating that. But there's really no barriers with what types of modules that are within an Epic that we can interact with from an automation perspective.
Yeah, that makes sense. Another really good question here is, how often do you have to update the automations and sort of follow up on, do you want to wait until it breaks, or are automations updated, are tracked
Yeah.
over the respective product launches? And product launches very much follows obviously the Epic release schedules and update schedules, I guess, in many times.
Yeah. So Zoe, I think that was your question. I appreciate that. I'm going to give you an answer that might be different than other people. And I would say continuous improvement is important for anybody, whether you're a person doing something or you're an automation doing something. And so this is what we have found with our clients, is that you have to continually work at your automations and you will find ways to make them better. If you're doing the proper QA, if you're doing the proper analysis, there's going to be changes that are made to automation because you say, oh, it can also do this, or you'll expand on it, or say, hey, if it did this, it would really be helpful. And so we have found that with clients is that as they're getting used to it, it's now ingrained in their operations. They're like, hey, if it could do this, this would be helpful. And so you want to always do that investigation, always be curious on how it can do better, just as you would with your own operations from a person perspective. You want to look at how the automations can be done better as well. So again, I always preach continuous improvement. We're always trying to do better. And the other thing is, I would say, is lean on your frontline staff, because they're the ones who are going to come up with a lot of these ideas, because they're really interacting with the automations, and take their feedback and see where you can run with it. And see what makes sense. Not everything's going to make sense. It works good for one person, but not the other 99, right? But really take their feedback and ideas and see how you can improve those automations.
That makes sense. That makes sense. We are sort of closing at the end time. We still have like 5 minutes to go, and a couple of questions that are still here. So let's go with this one. I think this is a good one for you because you're relatively new to automation. I mean, on relative terms, at least I get to say that because I've been here for years. So, and like, what, in your opinion, what are the key takeaways in starting your automation program? I mean, you have been on the opposite side of the table as well, and basically seeing it from the hospital's point of view, health system's point of view, and now on the provider point of view. But how would you sum it up? Like, how would you start if it was up to you?
Yeah. Wow. Loaded question. And I could go on for probably another 30 minutes on this. So yeah, I've been on the healthcare system side for a long time. I have been burned. I will say that, where I've had a vendor come in and say, oh, we can automate anything. And then I'm like, cool, let me show you my process. And they're like, whoa. You're talking crazy right now. So when you're getting kind of on your automation journey, so to speak, there's kind of two ways to do it. From my perspective, and then, coming from a healthcare perspective, is like, your organization has made this a priority and they want to start a program, like do it big, everything, and really jump into it. And so that's the one perspective, where when you're doing that, you need to do program development, right? And you need to start a center of excellence. You need to understand how you're going to govern it, how the budget's going to be, et cetera, all these different things. I would say that's a smaller subset than the organizations that want to kind of dip their toe into it. And so what I would say is when you want to dip your toe into it, it's a great opportunity to prove to your organization that it works, and that it can be valuable, and that it's, again, everybody thinks automation is going to take their job. That's not how it is. It's going to supercharge the people you already have. And when we do automate something that is, this status check, right? We're not getting rid of the authorization team, right? We're going to put them on more high value stuff, on submitting authorizations in a timely manner, right? 2 or 3 weeks out, as opposed to being like, oh crap, someone needs heart surgery on Friday, I got to submit it today. So, we're reallocating staff in that aspect. But as you want to dip your toe into it, I think one of the really good things is one thing I would always tell everybody, no matter whether you're dipping your foot into it or you're jumping in, head first, is start small. Start small, get quick wins, prove that it works, and you will get people that start to realize it, and then all kinds of things start coming out of the woodwork on people saying, hey, can we automate this? I heard about this. Can we automate this? So I would say start small. If you're doing it in-house, be careful about the money you're spending. And again, we saw this with a client with regards to licenses for software, and just be cognizant of that. I would say having a good partner is a great thing to do. And like at Digital Workforce, and again, now I'm being salesy, is you could start with an organization like us, and we have all the licenses, we have all we have the platforms, whichever one you want to use. And generally, we'll pick whatever works for your organization, or if you have a preference, we'll use that technology. And so you can kind of start out with us where you're just kind of paying on a monthly basis instead of doling out $1 million for a bunch of licenses, where you're in like a 2-year contract. So I think getting a partner that's done it before and worked with other organizations is really important, because I would say some of the groups we work with, the clients we work with, they've gone down maybe the wrong path, and it's challenging to start over, but sometimes it's necessary. And so you want to have someone who's going to tell you you're going down the wrong path, and be able to guide you on a right path based of experience. So, I don't know, does that answer the question?
It does. I would probably echo that based on last week's discussions in Phoenix. Is like never, and I'm sure you will echo this as well. Never underestimate the difficulty or the change management that needs to be done with the people. So it's automation is like that's just technology, but you actually have to change the way the organization approaches it if you're starting fresh, and that is something that needs to be addressed very early on. So because you're going to make people's life different, you're going to hopefully for the better, but it came up in the discussions last week many times where people just say like we didn't expect this to be so difficult internally, with our staff and whatnot. So I think that's a good thing to consider as well. We're sort of coming up to the end of our sessions, and we actually had a couple of questions there, but that's fine. I think in the chat, I think Ona put our contact information in the chat, and they're obviously available on the website as well. So very happy to connect after the webinar as well, and we can continue the dialogue like that with anybody who's interested. I don't think it's going to be the last one we're going to do, like the last session we do like this. I think I like the concept. I like the fact that we can just kind of talk and share our experiences and whatnot, and some of the cool automations that have been built and that are scalable across the industry. So not customer specific so much, but more on a generic level. And I believe your mind goes to the same place, Tom's mind, which we pretty much know what the next topic is, and hopefully we'll get to that in the coming months as well, because that is something that is fantastic for the industry, and very, very cool solution that once we're comfortable enough talking about it, I think we'll definitely have another session.
Spoiler alert.
Exactly. It's exactly. This new technology called faxing. So excellent. Well, thank you everybody for joining today. If you missed the live session, obviously this is being recorded, and the recording can be shared with your peers and colleagues and whatnot, friends and relatives. And it's been fun discussing, and thanks, Tom, for your insight and whatnot. I think that, very, very lengthy, 15 plus years industry knowledge really shows on these kind of things, and you're able to explain these things in a way that even I can understand part of it. So that is fantastic. So let's wrap it up. Any final words from you, Tom?
No, I mean, I think the biggest thing is that everybody's looking for automation and AI. It's the buzzword that everybody's looking at. Again, start simple, start small, but start, because it is coming, and it's one of the things that healthcare organizations have to start adopting, or they're going to fall behind. And again, the insurance industry has been using this for 20 years now, and we all kind of know the advantage they have. Sorry to any payers that might be on the call, but they do have an advantage. And so we've got to up our game from a healthcare perspective to compete. And we want to make sure, and again, like going back to this, it's all about, at least from a revenue cycle and patient access perspective, we want to provide our patients care, but we also need to be reimbursed for the care we provide. And so we're not doing anything that makes you crazy additional amounts of money and all this other stuff. It's making sure you get paid for what you provide and being able to do those services in a timely manner. And again, it goes back to a lot of this stuff is making sure that your patients can get the care they need. The authorization thing is the authorization's in place. We don't have to cancel your MRI and postpone it 2 or 3 weeks or a month or something like that. And so I think that's ultimately what this all comes down to, is making sure that the patients get the care that they need and deserve, and that the organization gets reimbursed for the care they provide.
Excellent. I think we can all be happy if we can help our clients and the industry in making that the reality. All right. Thank you again, Tom. Thanks everybody for joining. Thank you for the very lively audience and good questions. And we hope to see you soon in the next one.
Thanks, everybody.